Let's begin with renal system. So in renal system, the first topic is embryology. So the uh, pronephros develops in fourth week and it also ends in the fourth week, whereas the mesonephros begins in the fourth week, but it stays till first trimester of a baby. It acts like a kidney in the first trimester, and this mesonephros also converts into Wolffian duct in male, which forms epididymis and vas deferens. And metanephros is the one which develops in the fifth week, and it can stay whole lifelong as an kidney, because this is the one which can convert into kidney. So there's an ureteric bud which can form the ureter in future in the baby, and the metanephric mesenchyme along with the ureteric bud together form all the parts of the kidney like PCT, DCT, and even the full form of kidney. So you can see this is a urogenital sinus, like after the bladder, the urogenital sinus. If there's some obstruction of this ureter either by stone or some any kind of obstruction, then the fluid back up here, and that is called as hydronephrosis, which is seen mainly if this tubes fail to form, then you may get hydronephrosis. You can see here uteropelvic junction last to canalize. If there's congenital obstruction, there can be unilateral or bilateral. Most common pathological cause of prenatal hydronephrosis. Okay, in prenatal, if you get a hydronephrosis, that is because of this congenital obstruction of uretopelvic junction. Now coming to Potter sequence. So Potter sequence here, the problem is mainly the main trigger is oligohydramnios. Because of oligohydramnios, the fetus will get compressed and all the limbs will get deformed, and even you can see some facial anomalies like low set ears, retrogradnia, flattened nose, compression of chest, lack of amniotic fluid. So the main cause of death is pulmonary hypoplasia. This is caused by chronic placental insufficiency or reduced renal output, including autosomal recessive polycystic kidney disease, obstructive uropathy, bilateral renal agencies, all these problems. So babies who can't pee in utero develop the Potter sequence. So P here is pulmonary hypoplasia, O is oligohydramnios, T is twisted face, another T is twisted skin, E is extremity defect, and R is renal failure in utero. Now coming to horseshoe kidney. Horseshoe kidney is like the kidneys develop in them and they fuse together and they come below the inferior mesenteric artery and they just stay like that only. And actually these kidneys function normally, but only problem is they have hydronephrosis because uteropelvic junction obstruction, and you can also see renal stones, infection, and there's increased risk of renal cancer in them. You can see this kind of horseshoe kidney mostly in chromosomal aneuploidy cases like Turner syndrome, trisomy 13, 18, 21. Now coming to congenital solitary functioning kidney. In the name itself, you can see from the birth itself, the baby have two kidney, but only one kidney is functioning. And because of this, that kidney will have a lot of work and it will undergo hypertrophy process. Okay. Now coming to unilateral renal agenesis. It is a problem where already from the birth, the baby develops only one kidney, because the problem is differentiation of metanephric mesenchyme. So because as it is not getting differentiated, there is absence of kidney and ureter on one side. Now coming to multicystic dysplastic kidney. In the name itself, you can see there are many cysts develop because here the uteric bud is developed, but it is failed to differentiate with metanephric mesenchyme. Metanephric mesenchyme and uteric bud both should fuse, only then we can form a functional kidney. As there is no differentiation and meeting of this is non-functional kidney with many cysts and connective tissue. And this can be unilateral. Actually it is usually unilateral, but sometimes if it is bilateral, again it may lead to Potter sequence in babies. Now coming to duplex collecting system. Here the ureters will be duplex, like doubled, two sides. You will get 4 ureters. So because of this, what happens is this metanephric blastema is interacting more, so you're getting more number of ureters. So it is associated with vesicoureteral reflex, like the urine from the bladder will be coming up into the ureter and you may get lot of infection and obstructions. There's increased risk of urinary tract infection, and also you may have chance of hydronephrosis. Now coming to posterior urethral wall. Here the problem is like in the baby, the prostatic urethra is moving backward and it's blocked. So as it is obstructed, you see hydronephrosis, you see thickened and thick wall bladder, and a severe obstruction in fetus, which is associated with oligohydramnios here. And the most common cause of bladder outlet obstruction in male infants is posterior urethral wall. Now coming to vesicoureteric reflex. In the name itself, you can see vesica is from the bladder to the ureter. The urine is going back. As the urine is going retrogradely, Here, this abnormal insufficient insertion of ureter within the vesicular wall, or secondly due to abnormally high bladder pressure. This is leading to retrograde flow, and this increased risk of UTI is the same. Now coming to renal anatomy. In renal anatomy, one thing you know that renal have cortex, medulla. Cortex have more blood supply, whereas medulla have low blood supply. So whenever there's low blood flow coming to the kidney, then mostly medulla will get affected because already there's low blood supply, but the cortex is having high enough blood. So about left renal vein, we need to know left renal vein receives two other veins like left suprarenal and left gonadal veins. And coming to medulla, I already discussed about this. Left kidney, and one more thing, if you want to transplant the kidney, it's better to transplant the left kidney because left kidney have long left renal vein. So glomerular anatomy, we know we have afferent arteriole, we have efferent arteriole, we have juxtaglomerular cells which secrete renin, we have macula densa for sensing the sodium in the tube, and of course distal convoluted tubule, endothelial cells. And let us know the compartment, like what is mainly composed of membrane barrier here. This is the endothelial cells which are fenestrated, and here you have podocytes. You also have basement membrane which is maybe made up of type 4, and you can see the mesangial cells here, and this is the Bowman's capsule, and here starts our PCT. So coming to the course of ureters. Course of ureter, if you see, ureter actually arises from the pelvis and it travels under gonadal arteries over common iliac artery. So how to remember this is water under bridge. So in ureter there is water. What is the bridge? Bridges are uterine artery or vas deferens. So under uterine artery or vas deferens our ureter pass, and water flow over the iliacs, that is upon the iliac artery. Okay, below the uterine artery vas deferens or gonadal artery and upon the iliac artery. Okay, so if you do any gynecological procedures, you should always be careful because if you cut them, like if you ligate uterine artery or vessels, sometimes by mistake you can also cut the ureter and the urine may leak or obstruct, so that will be a problem. And if actually you may have doubt, like when bladder is contracting you are urinating, why your urine will not go upward? Because as your bladder is contracting, it is even contracting the urinary like ureter outflow pore, so that your urine will be coming only outward but not towards backside. Now coming to blood supply of ureter, proximal part of the ureter is supplied by renal arteries, middle part of ureter supplied by gonadal artery, aorta, common and internal iliac arteries. One more thing I want to say, proximal is supplied by renal because it's near to the kidney, middle is near to gonads, aorta, internal iliac, so it is supplied by that. In the distal part you can see it's nearer to internal iliac and superior vesical arteries, right? So it is near to like bladder, so that's why it is supplied by superior vesicle and internal iliac. So there are three common points where our urethra can block, like in uteropelvic junction over here, and next one is near the pelvic inlet, and other one is near uterovesical junction, that is between ureter and bladder. These are the 3 points where our ureter can block. Now coming to the fluid compartments, we know in a 70 kg normal healthy man you have like about 60% of intracellular like total body water, 60% of body mass and 40% of mass is non-water mass, and in that 60% of water mass again 40% is like intracellular fluid and 20% is extracellular fluid. Okay, and the 40% of intracellular fluid is mainly composed of potassium, magnesium, phosphate, ATP, etc. And the 20% of extracellular fluid is mainly composed of sodium, chloride, bicarbonate, albumin. Okay, and if you want to measure the plasma volume, you can measure it by radio labeling albumin. And if you want to measure the extracellular volume, you should use inulin and malitol. And the normal serum osmolality is like about 275 to 295 milliosmoles per kg per water. And the plasma volume is total blood volume into 1 minus hematocrit. I already discussed about glomerular filtration barrier. It is mainly made up of fenestrated capillary endothelium, basement membrane with type 4 collagen and heparin sulfate, and visceral epithelium consisting of podocyte foot process. And one more thing, this glomerular filtration barrier is having negatively charged particles. Most of it is having negatively charged particles, so that it will not allow proteins to leak into urine, so that it can stop protein leakage in the urine. Now coming to renal clearance, you need to learn some formulas here, like C clearance. C is equal to urine volume by P is plasma concentration of urine. Okay, so if the clearance is less than GFR, like you're clearing only some urine when than expected GFR, then you can understand this absorption of urine, right? If the clearance is greater than GFR, like if you expect to get more urine than the GFR, that is like you're secreting from the tubules. If your clearance is equal to GFR, that is like there's either no secretion or reabsorption. Now coming to glomerular filtration rate. Glomerular filtration rate can be artificially measured by using inulin and naturally measured by using creatinine. And the formula is C is equal to GFR is equal to U into V by P. The same formula for clearance, but U into V by P. V by P will be coming towards this side. And one more thing you need to know, in the Bowman's capsule, in the glomerulus, there's hydrostatic pressure and as well as oncotic pressure. Okay, and the normal GFR per minute is like about 100 milliliters, and the creatinine clearance is what we measure for natural GFR. Okay, now coming to renal blood flow autoregulation. Our kidneys can autoregulate themselves whenever they need blood, whenever they don't need blood. Okay, so that is done by myogenic, that is of two types, myogenic and tubuloglomerular. Myogenic is where whenever there is more arterial pressure or afferent arteriole will stretch and it will lead to constriction of afferent arteriole and decrease renal blood flow. Tubuloglomerular is especially macula densa, sends the sodium tonicity in the blood and it will report to some afferent arteriole so that it will constrict again and decrease the renal blood flow. So whenever you get more blood flow, your afferent arteriole will get constricted and it will limit the blood flow to the glomerular filtration rate so that you can get proper amount of urine. So this is autoregulation done by myogenic and tubuloglomerular. Now coming to effective renal plasma flow. So effective renal plasma flow is measured by para-aminohippuric acid, and here we see measure between the filtration and secretion. And if you give para-aminohippuric acid to anyone, 100% of it will be getting excreted out. So the formula here is RPF is equal to U into V by P, which is equal to C. Okay, and one more thing, from our heart, like 20 to 25% of our blood is only purely for our kidneys regulation. Okay, now coming to filtration fraction. Filtration fraction is equal to GFR divided by RPF, and the normal filtration fraction is like about 20%. So you can see here filter load is equal to GFR into plasma concentration. GFR can be measured naturally by creatinine and RPF can be measured by PAH, right? Prostaglandins dilate the efferent arteriole angiotensin to constrict the efferent arteriole. Okay. Now coming to changes in glomerular dynamics. If your efferent arteriole get constricted, your GFR will drop, your renal perfusion pressure will drop. Of course, filtration factor no change. Efferent arteriole will get constricted, your GFR will rise, your renal perfusion pressure will drop, filtration factor will rise. Plasma protein concentration increase, GFR drops, RPF no change, filtration fraction drop. Plasma protein concentration decrease, then GFR will rise, no change in RPF, rise in filtration. So if GFR rise, filtration fraction also rises. If there's constriction of ureter, GFR drops and even filtration fraction drops. If there's dehydration, of course GFR drops, renal perfusion flow will drop a lot and the filtration fraction will rise here. This is a like thing which you need to remember. Now coming to calculation of reabsorption and secretion. So if you take the filter load formula, it's GFR into P and excretion is V into U. Okay. Reabsorption rate is equal to filtration minus excretion. Secretion is equal to excretion minus filtration. And the formula for GFR is U into V by P. Now coming to glucose clearance. Actually, the normal glucose range is like 60 to 120. In that time, our PCT can, take up all the sodium and glucose together in the PCT by SGLT2, right? But in adults, sometime if the glucose level is like about 200, at that time our SGLT2 will get saturated so that it leaves the glucose in the urine, and that is called as glucosuria. So in glucosuria, like about 375 milliliters, all transporters are fully saturated, right? But in normal pregnancy also our urine will have glucose, that is glucosuria is common in pregnancy. We just no need to worry, because in pregnancy GFR rises, filtration of substances rises, glucose threshold also rises, so that will lead to glucosuria. Okay, Now coming to SGLT2. If we block SGLT2, what happens? You can understand, if we block SGLT2, sodium and glucose will not get absorbed and all the glucose will be diverted into the urine. So this is good for diabetic people because diabetic people already have hyperglycemia in their blood. So if we remove most of the glucose by the urine, it's better for them. Glucosuria is an important clinical clue for diabetes mellitus. Now let us see splay phenomena. So splay phenomena is nothing but like the TM for the glucose rises gradually but not sharply. Here you can see the splay phenomena. It is deviating slowly. It's not rising sharply. So that is splay phenomena. Now coming to nephron transport physiology. So first we'll begin with PCT. In PCT you can see this is an apical membrane where it is towards the urine side, and this is a basolateral membrane, this is towards the blood side. Okay, so first the sodium and glucose co-transporter work on the PCT, and it absorbs maximum 100% of sodium and glucose into the proximal convoluted tubule. Now comes the angiotensin 2. Angiotensin 2 absorbs more sodium and it takes hydrogen out into urine. So now this hydrogen combines with bicarbonate in the urine to form H2CO3. Now this H2CO3 in the presence of carbonic anhydrase converts into carbon dioxide and water. And now this carbon dioxide and water enters into the cell, and again in the presence of carbonic anhydrase it's converted into H2CO3. This H2CO3 again splits into bicarbonate and H+. This H+ continues the cycle and this bicarbonate goes into basolateral membrane. So this is the process which is going on in the proximal convoluted tubule. Now coming to thin ascending loop of Henle. So after proximal convoluted tubule, we move on to descending loop of Henle. Descending loop of Henle just absorbs all the water from the urine and it concentrates the urine, makes the urine hypertonic. So it's a hypertonic concentrating segment. Now coming to ascending loop of Henle. This diagram shows ascending loop of Henle. Here mainly there is sodium potassium chloride transporter which takes all the sodium potassium chloride. This is just opposite to descending loop of Henle. Here we take all the nutrients like sodium potassium chloride into the cell, and also the magnesium and calcium moves paracellularly in between the cells. So all the nutrients are absorbed and only the pure fluid is remain now in the ascending loop of Henle, and this pure fluid is now hypotonic. So before in a descending loop of Henle it is hypertonic, in ascending loop of Henle it is hypotonic. So now this hypotonic fluid moves into distal convoluted tubule. In distal convoluted tubule, we know again we have apical membrane, basolateral membrane. In apical membrane, mainly the sodium and chloride are reabsorbed in the distal convoluted tubule. Of course, magnesium, calcium follows it. So this is distal convoluted tubule mainly absorbs calcium. So calcium is absorbed mainly in distal convoluted tubule. So parathyroid hormone, whenever it needs more calcium, it just activates the DCT to absorb more calcium so that it can rise the calcium levels in the blood or serum. Now the urine moves on to collecting tubule. In the collecting tubule, we know we have three types of cells: principal cell, alpha intercalated cell, and beta intercalated cell. So in principal cell mainly our ADH acts. You know ADH by means of V2, it forms aquaporins on the apical membrane and it allows more water to come into the principal cell. So there's also aldosterone. Aldosterone works on principal cell as well as on alpha intercalated cell. On principal cell, aldosterone helps to retain sodium and water and release potassium into the urine. Whereas aldosterone on the alpha intercalated cells mainly releases hydrogen ion into the urine. So this is the function of collecting tubule. So finally the urine comes out. So this is nephron transport physiology. Now let's come to renal tubular defects, and the mnemonic here is Fanconi Beagles. So the diagram helps us to understand this. Fanconi is where there's problem in PCT. You know in PCT we absorb sodium, potassium and glucose, amino acids. So if there's Fanconi syndrome, there's a problem in absorption of all this. So the urine will be having all these nutrients and the baby have developmental defects because all these nutrients, important one, are going in the urine. So mainly they have metabolic acidosis, hypophosphatemia, hypokalemia. Now coming to Bartter syndrome. Bartter syndrome affects on ascending loop of Henle. So the same. If the ascending loop of Henle is affected, you can't absorb your sodium, potassium, chloride, magnesium, calcium. So all this will be wasting in the urine and again the baby will become weak. And here you get metabolic alkalosis, hypokalemia and hypercalciuria. Very important to remember hypercalciuria. So you're losing calcium in the urine. So this baby may present with some bone problems. Now coming to Gittelman syndrome. Gittelman syndrome acts mainly on the DCT. So in the DCT, you can't absorb more sodium, chlorine and also calcium. So Gitelman syndrome presents with metabolic alkalosis, hypomagnesemia, hypokalemia, and hypocalciuria. The last one is Liddle syndrome and same. So same is nothing but syndrome of apparent mineralocorticoid excess. This both syndromes affect on your collecting duct. Here the problem is there's more sodium, this gain of function. There's more sodium reabsorption, so you may get hypertension here. So you can see metabolic alkalosis, hypokalemia, hypertension, and decreased aldosterone. The problem is low aldosterone. And in same you have metabolic alkalosis, hypokalemia, hypertension, decreased aldosterone, and the same. So Liddle and same syndrome are same. Now coming to relative concentration along proximal tubule. Actually this table says like what are going in the same way. Tubular fluid divided by plasma. If the tubular fluid divided by plasma is equal to 1, that means the sodium and water are, the solute and solvent are absorbing at the same rate. The example is sodium and potassium, which are absorbed in the same rate. And if TF by P is greater than 1, it means solute is reabsorbed more quickly when compared with solvent. So here PAH, creatine, inulin, urea. Sorry, here this means solute is reabsorbed less quickly when compared with water. Here PAH, creatine, inulin, urea, chlorine come under this. Next coming to TF by P less than 1. This means solute is reabsorbed more quickly than water, like bicarbonate, amino acids, and glucose. Let's move on to renin, angiotensin, aldosterone system. So first thing, whenever there's any change, especially when there's low blood pressure in the efferent arteriole, our juxtaglomerular cells catch, like they come to know, oh, there's low blood in efferent arteriole, so let's activate renin. So it will just go and activate renin, and this renin will convert our angiotensinogen to angiotensin 1. And from the from the lungs, our ACE comes into play and converts this angiotensin 1 to angiotensin 2. And this angiotensin 2 will lead to vasoconstriction of our blood vessel and rise the blood pressure. It can constrict the efferent arteriole and increase the filtration fracture. And also it will activate the PCT cell to absorb more sodium and more hydrogen ions so that it can raise the blood pressure. And it also activates the aldosterone, especially aldosterone actone alpha intercalated cell, and lead to more H plus secretion. And this also goes and acts on ADH, especially on posterior pituitary. So it will act on principal cell and release more sodium and so release more potassium, secrete more potassium, and reabsorb sodium and water so that we can raise the BP. So the main function of renin, angiotensin, aldosterone system is to raise our blood pressure whenever we have low blood pressure. But opposite to this, we have ANP and BNP, which are released from our heart whenever we have high blood pressure. So in high blood pressure case, we want to stop this RAS system. So this ANP and BNP immediately stop the RAS system so that we can again balance the blood pressure back to normal. So the same thing what we discussed is here, juxtaglomerular apparatus. Now coming to kidney hormone functions. In kidney we have different hormones like erythropoietin, vitamin D, prostaglandin, dopamine. So erythropoietin is released by interstitial cells in peritubular capillary whenever there is hypoxia. In this case, this goes and stimulates RBC proliferation in bone marrow. So that's why whenever we have kidney problem, we may also get anemia because erythropoietin is deficient. Next coming to vitamin D, it is activated into 125 hydroxy vitamin D in the kidney, mainly by presence of 1 alpha hydroxylase. Next coming to prostaglandins, we know they are vasodilators which actually increase the renal blood flow. Now coming to dopamine, if dopamine is more, they'll constrict the efferent arterioles. If dopamine is low, they'll lead to vasodilation. Now coming to potassium shift. So whenever we have more potassium in our blood, we say hyperkalemia. That means there's more potassium in blood, but